Hello, I'm Dr. Ken Landau. Thanks for watching. Let's talk about rosacea. It was formerly called acne rosacea. It's a chronic, long-term inflammatory skin condition that tends to affect the central face. It affects the nose and the cheeks and the forehead and the chin. It seems to come and go. Maybe as many as 16 million Americans have rosacea, but 80% of them have not been diagnosed. It's a peculiar condition. We don't understand the cause or the genetics or the pathophysiology. The treatment is misunderstood. It's often inexpensive. It's not curative, and it only temporizes. Anywhere between 1 and 22% of the population has the condition, depending on how it's defined, but typically it occurs in people in their late 20s to 50 years old or thereabout. It's not uncommon to have manifestations of pre-rosacea in teenagers and young adults. Women appear more often affected than men. Seems more common in people who have fair complexions, typically Northern European background, but it's not uncommon in Latin Americans or Asian Americans or African Americans. We have different types of rosacea, and each type has a different kind of manifestation and different kind of treatment. So there's redness that comes and goes. Ultimately, it may persist. It can be diagnosed as an exaggerated flush or a blush. Then we have papules and pustules that look like acne, except there are no blackheads and whiteheads. Then we have some areas of thickening of the skin, localized thickening of the skin, maybe involving the nose, could be the forehead or the cheeks. And sometimes we have some eye involvement. The eye involvement can occur by itself or with the skin manifestations. Now, in some people, the disorder may lead to lack of self-esteem or some problems with confidence or embarrassment. But for the overwhelming majority of people with rosacea, that's not an issue and shouldn't be used as, well, you have the disease and you have to have a treatment. It's you have a treatment because it bothers you. Well, there are a lot of different classifications for the condition. The classifications are constantly being updated. None of them appear to be permanent. We have 4 basic types. We have one that we call the erythematotelangiectatic type. We'll simply refer to it as ETR. It's persistent redness of the central portion of the face. Originally, it comes and goes like a flush or a blush, and ultimately, the redness stays, and ultimately, after we have some of the redness, we get some dilated blood vessels, and the dilated blood vessels on the cheek or on the nose or on the forehead seem to persist. The most common type of this ETR occurs in women more so than men. Starts off with a prolonged, more than a 10-minute flushing reaction to various stimuli. It's often not diagnosed as rosacea. These people tend to blush easily in response to some sort of a trigger, and the trigger could be emotional stress or hot coffee or hot tea or alcohol, spicy food, exercise, cold weather, hot baths, exposure to the hot sun, not the wintertime sun, but the summertime sun, because it seems to be the heat is the precipitant. And oftentimes, people who have this ETR, not only do they have the flushing and the blushing and the persistent redness, but they can have skin that seems to burn or itch or sting or be dry or flaky. And sometimes they just simply refer to themselves as having sensitive, dry skin. Ultimately, the redness might fade some, but it can leave some blood vessels dilated that persist permanently. And sometimes the skin seems to be red and swollen, and it may persist for long periods of time. The site of involvement is the central face. Sometimes it also involves the ears, the neck, the upper chest, the upper back, but it tends not to involve the area around the eyes. On the other hand, the papulopustular type looks like acne, except no blackheads, no whiteheads. Tends to occur in adults, young adults, middle-aged adults. Tends not to be diagnosed in people who are in their 20s because it's often misdiagnosed as acne. Involves more often women than men. We can have lesions that look every bit like acne. The papules and the pustules, the red bumps on the surface of the skin, sometimes filled with pus, sometimes not. Episodes can last very briefly for several days, more typically several weeks. Ultimately, again, they leave the skin slightly swollen, and it doesn't completely return to normal. Then we have the phymatous type. The phymatous type is more in men than in women. This is the type that's more in men than in women. It's thickened skin, enlarged skin, irregular surface or nodules on the surface of the skin, dilated follicles, areas with sebaceous oil glands that seem to be dilated. Typically on the nose, that's rhinophyma for older people. It's the W.C. Fields nose for younger people. It's the President Bill Clinton nose. You get the same sort of thing on your chin or on your forehead or in the ears. The skin is hard and it's fibrous and it's thick. And then we have the ocular form. The ocular form, frequently diagnosed incorrectly as just dry eyes, it's present in up to 50% of the people who have cutaneous manifestations. Usually the skin problem comes first, then the eye, but in about 20% of the time the eye manifestations occur first. And some people don't even get any skin manifestations. Tends to involve the eyes and the eyelids that can become red or inflamed or dry or irritated. You can have a gritty sensation or foreign body sensation. Your eyes can be watery or burning or sting or sensitive to the light. At the base of your eyelashes, sometimes you have a honey-colored crust. Excessive tearing and tear dysfunction and styes and chalasia are not uncommon. Conjunctivitis and dilated blood vessels at the base of the eyelid margin. Some people develop even blurry vision. Now, typically you have just one subtype. So you either have the red subtype or you have the papulopustular subtype. One of those two major manifestations, or the phymatous type. When it recurs, you tend to develop that same stage. So it doesn't seem to be a progressive disease. So you don't go from the red stage to the acne stage to the nodular stage. That can happen, but not very commonly. The redness phase, the erythematous phase, occurs in somewhere around 9% of the population. The acne stage, the papulopustular stage, about 3% of the population. The phymatous form that doesn't come and go, that occurs in about 0.5% of the population. And the eye manifestations in anywhere between less than 10% to more than 50% of the people who have rosacea, depending on whether they complain about a problem and go see an eye doctor or go to a skin doctor complaining of a problem with their eyelids. Well, in general, we know that there are certain features that seem to be present in any of the forms of rosacea, and they can include some burning and stinging and dryness and some swelling. No test available to make the diagnosis. It's a visual diagnosis. Can't even do a biopsy. A biopsy just show, for the red skin part, just dilated blood vessels. For the papulopustular acne form, would just show an acne-like eruption. For the phymatous form, the nodules, the lump form, it would just show some big oil glands and some scar tissue. Well, it can be misdiagnosed to several other kinds of conditions. It can be misdiagnosed as a gram-negative rosacea. These people taking the antibiotics for a long period of time, oral antibiotics, and then some bacteria become resistant, and then the bacteria start to grow and form little pustules, little acne-form lesions with E. coli or Klebsiella or some other kind of organism. And then we have steroid rosacea. People who apply prescription strength, high potency steroids to the skin seem to get a little bit better, so they keep using it because every time they stop using it, what they call rosacea seems to flare. But what they're really suffering from is steroid overuse, steroid rosacea, and a related condition when it occurs just around the mouth or just around the eyes, we call that perioral dermatitis. The cause seems to have a lot to do with genetics. Certainly, the people who are predisposed are Northern European. Genetics have an awful lot to do with it. Maybe as much as 50% of rosacea seems to be controlled by your genes. But what the genes do and how they make you susceptible, we don't know. They certainly can seem to make you susceptible to certain kinds of triggers, like temperature and ultraviolet light, especially the heat, and certain kind of bacteria and microbes and certain food products and spices and stresses. And we also know that sometimes people who have rosacea are predisposed to other kind of ailments. So they have a tendency to have more migraine headaches, or they have more depression or more anxiety, and sometimes they have some autoimmune conditions. But what's the current theory? The current theory is that the reason the disease arises is because of an interaction between the skin cells that are called keratinocytes and some of the sensory nerves that go to the skin. And it does this via something known as the TRPV, and that stands for transient receptor potential vanilloid. And the receptors there seem to make a person sensitive to heat and alcohol and inflammatory stresses and perfumes and herbs and things of that nature. And then we also have the ability of those things, whatever the things are, to stimulate the toll-like receptors, which is a type of an innate immune system that you were born with, that everyone has. And it seems that that system is highly reactive in some people. And it's sensitive to ultraviolet light or physical injury or emotional stress or even some vitamin D and sometimes from the chitin on some Demodex that happens to be on your skin. And it all seems to be a little bit fishy if you ask me. But those are the current theories. And some people say it has to do with some of the staph epidermidis on your skin that might be a little bit different than normal, or the Helicobacter pylori that grows in your stomach. Or some people say it has to do with the little mite. Well, we're not exactly sure whether any of those things are relevant. But when we look at somebody who has what looks like it might be rosacea, we have to say, well, could it be seborrheic dermatitis or dandruff of the face, which is extraordinarily common? Or is it this perioral dermatitis? Or is it acne? Or does the person just suffer from menopausal hot flashes? Or chronic actinic, chronic sun-related disease or damage? Or is it lupus? Well, there's no cure for the condition. We can identify some triggers in those people, especially who have either the erythematotelangiectatic type or the papulopustular type, and in those people we avoid the triggers. So the triggers are heat-related oftentimes, so it's hot coffee, hot tea. It's not the caffeine, it's the heat. And same too with the sun. It's the sun in the summertime. It's the sun when you get hot. So you wear a big hat and you hold a cold can of soda up against your skin so that you can keep it cool in the summertime. The sun in the winter doesn't seem to make all that much difference. Alcohol makes the skin hot. It causes the dilation of the skin blood vessels, makes the skin hot. So don't drink alcohol. It's probably going to flare up your rosacea. And if you have sensitive skin, be careful. Especially in the erythematotelangiectatic type, you have to be careful with the cleanser you pick. You don't want to scrub. You don't want to be rough with your skin. You want to moisturize. But your skin's sensitive, so the kind of moisturizer and the kind of soap that you pick that your skin seems to tolerate is trial and error, and you can cover it up pretty much with some makeup. But again, it's trial and error because a lot of makeups might irritate the skin and further compound the problem. And then when you exercise, if you have the erythematotelangiectatic type, well, you got to be a little careful with too much exercise. Every 10, 15 minutes, you might want to hold a cold can of soda or a cold glass of ice up against your skin. If you're exercising on a treadmill, put a fan in front of it. And recognize that each different type of rosacea has its own kind of treatment. So with the ETR, we avoid the triggers, we keep the skin cool, and we can use some topical blood vessel constrictors. That would be something like oxymetazoline cream, but that's basically the same thing as you could get much cheaper with Afrin, or even cheaper yet with the generic form of Afrin. Put a couple drops of that on your hand and rub it onto your face when the face is red, when the blood vessels are swollen. Yes, the prescription kind is a higher concentration, might work a little bit better, but not all that much helpful as far as I'm concerned. We have the beta blockers that some people who seem to be stressed, maybe the beta blockers are helpful for those people, usually used for blood pressure problems or cardiac arrhythmias, but they can be helpful for the skin. Topically, sometimes some over-the-counter hydrocortisone might be helpful for a short period of time. Things like Elidel and Protopic tend not to be very helpful. If somebody has the erythematotelangiectatic rosacea and is really troubled by it, well, there's the pulse dye laser and the IPL. They're temporarily helpful, but they're not curative. They're a little expensive. And unfortunately, they don't prevent the recurrences. If you have the acne form, there's no better treatment, basically, than the topical benzoyl peroxides. We have the old-fashioned remedies like the sodium sulfacetamide that's been around forever. or you could use some topical metronidazole. That's a prescription. It's an antibiotic that can be used topically on the skin, or azelaic acid, also called Azolex. That can be used. Those are moderately helpful. The ivermectins and the retinoids and the topical antibiotics might not be as helpful. Sometimes oral antibiotics could be helpful. In the tetracycline family, the two standards are either doxycycline or minocycline. There was a push to use lower doses, or what's known as the sub-antimicrobial dose. Those are very expensive and not really any better than using the standard therapies that are available as inexpensive generic drugs. Sometimes if you have bad enough papulopustular rosacea, it might be appropriate to consider a drug like Accutane. It's off-label. It's used at a relatively low dose, much lower than the standard for acne, but there are no real good guidelines for using the drug, and it does cause some major problems. For the phymatous form, those nodules, well, we have surgery, or we have cautery, or we have the CO2 laser. And for people who have the ocular rosacea, well, the treatment varies depending on the kind of manifestations that you have. So oftentimes it's eyelid hygiene that's appropriate. So warm water, eyelid scrub sometime, artificial tears, gentle cleansing, sometimes a topical cream. Topical antibiotic might be appropriate, an oral antibiotic might be appropriate. But it's important to realize that, one, our treatment doesn't cure the disease, and two, the goal is to prevent the flare. So identify those particular situations that cause your rosacea to flare and try as hard as you can to avoid them. You could use topical medicine or oral medicine, whatever seems to work best in your particular case. Realize that you don't necessarily have to be on long-term therapy. You get the condition under control, and then you can taper or stop the medicine and wait until it flares again, and then go through the same sort of a cycle. Well, it's a disease that an awful lot of discussion has been bandied about, but the question is, does everybody who has rosacea need therapy? Well, you have to realize that the diagnosis from doctor to doctor of rosacea isn't necessarily consistent. So you can go to some doctor and have him say that, well, it looks pretty normal skin. But at other times, you could be flaring and you could have red skin, or you could have the pimples and the pustules, and the doctor says, oh my goodness, yes, you need treatment. So you have to sort of decide what treatment is appropriate, and you have to consider that the kinds of treatment we have for the erythematotelangiectatic rosacea don't work in the papulopustular rosacea, and vice versa. And none of those therapies works in the phymatous type. And of course, the ocular rosacea needs something completely different. So anyway, thanks for watching. I'm Dr. Ken Landau.